Hello, everyone, and I'm really thrilled to be bringing back a lecture on echo at Nepean. We've been quiet for a little bit, and I can't think of a better way to bring 2025 to an end and to talk about 2026, where we'll be doing a lot more echo in critical care education, and to see out 2025. It's a great pleasure to introduce a friend of mine, Hatem Soliman-Aboumarie, who is a consultant in cardiothoracic ICU and ECMO at the Harefield Hospital in Royal Brompton. He's an assistant professor with King's College London, the School of Cardiovascular and Metabolic Medicine and Science. And he's also the secretary on the executive board with the EACVI, with the European Society of Cardiology. Hatem, thank you. It is an absolute pleasure to be talking to you tonight, my time in Australia, and morning time in London. Thank you for getting up early to give this lecture. Over to you for the next half an hour or so, Hatem, and thank you very much for giving us this lecture on echocardiography and cardiac arrest. Thank you.
Thank you so much, Sam. Good morning from London. It's a real honor and pleasure to be with you in this lecture. And thank you for the wonderful work you and your team in Nepean are doing. It's a leading educational platform. And as I told you earlier, many people around the world are benefiting from this wonderful educational platform. So in the next 25 minutes, I'm going to go through some insights on how I see the role of echo and ultrasound for managing patients with cardiac arrest. I have nothing to disclose in relationship to this talk. And the outline of the talk will include trying to answer three key questions. The first question is, why is it needed? The second is, what is the evidence? The third, how is it integrated? So let's try to answer the first question. Why do we need echo for cardiac arrest? You could see from these relatively old studies and data that there is a huge percentage of patients whom professionals probably will miss the absence of pulse during cardiac arrest, about 50%. And also we know from the literature that lay people miss the absence of pulse in nearly 100% of cases. And this uncertainty is responsible for delays of early onset of chest compression, which is crucial for the outcome of cardiopulmonary resuscitation. And this is from the focused cardiac ultrasound curriculum of the EACVI, where the message was very clear that the focused cardiac ultrasound performed should not be a replacement for diagnostic echocardiography. So whatever type of echo we do in these situations and in this context is just a point of care targeted focused assessment, and it does not replace the specialist level comprehensive echocardiography. So why is it needed? It is important because it can reduce the list of differential diagnosis, and it can address different reversible causes of cardiac arrest. These are the main four H's and four T's, and you can see that almost 50% of these four H's and four T's can be directly evaluated using ultrasound and echocardiography, whether hypovolemia, tamponade, tension pneumothorax, pulmonary embolism, or coronary thrombosis or coronary infarction, myocardial infarction, and also the other causes of cardiac arrest, whether it's hypoxia, metabolic disturbances, or toxins. It can be indirectly assessed by looking at the effect of these disturbances on the heart during cardiac arrest. And these are the different main reversible causes of cardiac arrest. You can see the examples on echo. And actually, the ones highlighted in red, tension pneumothorax and the cardiac tamponade, are the ones in which echo can directly provide the diagnosis on the spot. Echo alone in this context can provide diagnosis, which whether it's cardiac tamponade or tension pneumothorax, which could potentially save life at the timing of identification during cardiac arrest. And then when we started doing echo in cardiac arrest, we later identified the differences between two entities, the true pulseless electrical activity and the pseudo pulseless electrical activity. The true pulseless electrical activity is a situation where you don't feel pulse, but you also don't see any cardiac activity on echo. While the pseudo pulseless electrical activity is a situation where, yes, you also don't feel pulse, but on echo, there is a residual cardiac activity seen on ultrasound, which might have some um, um, implications on uh, determining the timing of stopping chest compression. Of course, this will be individualized according to the patient context, but this is something we were not able to identify before starting using echocardiography. And another interesting reason or way of using echo during CPR is for pacemaker optimization. And this is a very nice study which looked at using ultrasound to determine external pacemaker capture during resuscitation, which is also very useful. The second question is, what is the evidence? Which is a big question. We have, of course, to ensure that what we are doing has some evidence or looking for gaps of evidence, what we need to do more to make sure we are doing the right thing for our patients. You can see here, this is probably one of the earliest data which were available in the context of resuscitation more than 20 years ago. It was a randomized control trial which compared immediate versus delayed goal-directed ultrasound to identify the etiology of non-traumatic hypotension in emergency department patients. And the study results found that incorporating goal-directed ultrasound in the evaluation of these patients resulted in a fewer viable diagnostic etiologies and a more accurate physician impression of final diagnosis. So it's one of the important studies which opened for us the frontier for using ultrasound in an impactful way in these patients. And then this is another very important study. It's another actually a landmark study in the field of cardiopulmonary resuscitation and the use of echo, performed by Bright Kreutz and his team back in 2010. And you could see here that the study found that performing echocardiography in patients with suspected pulseless electrical activity, it was able to identify that patients with suspected pulseless electrical activity, 58% of them had pseudo pulseless electrical activity, so they had cardiac activity. And patients with suspected asystole, 35% of these patients had wall motion, which is really, really important. So the study opened our eyes to understanding how ultrasound can reliably increase the chances of understanding whether we have a true asystole or true pulseless electrical activity, which encouraged us later or encouraged ultrasound practitioners to integrate ultrasound in resuscitation, in a cardiopulmonary resuscitation. And then came, based on this study and other studies, came the earlier recommendations of the International Consensus on Cardiopulmonary Resuscitation with these treatment recommendations. Of course, they said that ultrasound can be used during resuscitation, but they said that this should be done without interfering with the standard ACLS protocol, but it can be used as an additional diagnostic tool to identify potentially reversible causes. And the key question that remained is echo able to prognosticate? So far we have data that echo can be added as an additional diagnostic tool without interfering chest compression, which is great. But the question now is, are we able to prognosticate using echo? And then comes this large study, multi-center study, 20 centers in the United States and Canada, prospective study, observational, non-randomized. It was protocol-driven, which is one of the strengths of this study, and it included 793 patients. And they included in the study patients who presented to the A&E with non-traumatic cardiac arrest, asystole, or PEA. And the endpoint was the primary outcome, which was ROSC, and the secondary outcome was survival to hospital admission and discharge. And you can see the results. They were really interesting. You see that in patients in home ultrasound was used, the survival was significantly higher than patients who in home ultrasound was not used in determining ROSC. And on admission, also ultrasound was the utilization was much more associated with survival on admission compared to patients in home ultrasound was not used. And also there was some benefit in patients in home ultrasound was used at discharge compared to patients in home ultrasound was not used. So this was encouraging, but we remained, or as mentioned by the 2020 executive summary of the ILCOR, remained with lots of biases, limitations, and uncertainties. And this is summary of some of these limitations and uncertainties. The first one was that clinicians were not blinded to echo findings. So echo sometimes can be a self-fulfilling prophecy to confirm our bias or confirm what we want to see. And that can be potentially dangerous when we interpret echo in resuscitation. Also, another limitation was that the clinical outcomes beyond ROSC were not factored in. So the results of the studies were not adjusted for other prognostic factors. The studies we had so far had only strong outcomes, and there were no specified timing for echo in relation to initiation or cessation of cardiopulmonary CPR, cardiopulmonary resuscitation. And also the studies were flawed by the lack of a clear definition of the echo findings. For example, mentioning agonal activity with non-shockable rhythm. So there was some ambiguity around some of the definitions, and they were missing data from some of the studies. So based on that, based on all these limitations, biases, and uncertainties, the task force of the ILCOR in this executive summary in 2020, they advised against the use of point-of-care echo for prognostication during cardiopulmonary resuscitation. But I think it's still work in progress. But this is where we are at the moment. We should not use echo to prognosticate, but certainly we can use it, and it's advisable to use it as an additional diagnostic tool to identify reversible causes of chest compression. So now we are reaching a different context, which is optimizing resuscitation. Can we use echo to optimize the outcome of resuscitation, especially transesophageal echo? This is a very exciting and evolving new field where this is one of the earlier studies. It included small number of patients, and the results were impressive because the study found that using transesophageal echo to optimize chest compression and the position of the hand on the chest during CPR, they found that the patients who had obstruction of the LVOT or compression of the LVOT during chest compression, they all died. And that was really, really important to see. While patients who had compression of the right ventricle without interference of the LVOT, these patients had a better chance of survival. There are more studies being performed mainly by Philip Terran and colleagues in North America, where they try to look at more evidence to try to integrate that into cardiopulmonary resuscitation, because it's a very easy. Transesophageal echo now is more widely available in many intensive care units and emergency departments, and it can be used in an integrated manner during CPR. In a peri-arrest situation, or once the patient develops cardiac arrest, just putting the TOA probe down, and you make sure that when chest compression is done, that the compression happens to the RV and not the left ventricular outflow tract. And this is how it looks like. You can see here on your left-hand side, this is um, before optimizing the positioning of the chest compression, that the LVOT is getting obstructed. But after optimizing the position of the hands on the chest, under the TOE guidance, you can see on your right-hand side that the RV is getting compressed and not the left ventricular outflow tract. And this is a wonderful paper by Philippe and his team, which explains the use of focused transesophageal echo during cardiopulmonary resuscitation, not only to enhance quality of CPR, but also to provide procedural guidance, to do what we discussed earlier, which is looking for different reversible causes of cardiac arrest. And in our latest European consensus document on the use of cardiac ultrasound in cardiovascular emergency and critical care, we concluded with this statement after discussing with the panel of experts on the consensus document. And we said that incorporating cardiac ultrasound into ALS protocol and the management of cardiac arrest enhances the ability to diagnose underlying pathophysiological conditions, which would help to tailor resuscitation efforts. We also said that cardiac ultrasound is challenging during cardiac arrest. Therefore, proper training and coordinated teamwork are essential for timely data acquisition and interpretation, and to ensure minimizing interruption of chest compressions. So the last question is, how is it integrated? Which I think is a very important question, because we can have evidence, we can know that we need it, but we might integrate it wrongly. So it's important to integrate it properly within our clinical practice. And these were many structured frameworks and protocols which were developed over the last 15 years. The FEEL course, the FEEL protocol, the FEAR, the CASA, the CAUSE, the SESAME. There are many, many protocols. And all of them try to integrate the use of ultrasound during cardiac arrest and resuscitation. And in this pyramid of competence of critical care echo, the use of emergency echo during cardiac arrest lies at the base of that pyramid. So this is the foundation. This is the entry level to performing echocardiography. And we're not saying that it can be safely performed by beginners who have very limited experience, but we are saying that the amount of information needed to integrate in that context is the information fulfilled in that competency level of critical care echocardiography, which is the basic level. But of course, some patients require much more experience and much more competency levels in interpreting the information. And this is the Resuscitation Council of the UK, the FEEL, Focused Echo in Emergency Life Support. This is an algorithm. It's a national course where echo is structurally integrated in doing cardiopulmonary resuscitation. And you can see here that clearly the echo is applied in the non-shockable rhythm of CPR. So never to interrupt the shockable rhythm. Patients in shockable rhythm, VT/VF, you have to provide shock and then immediately resume CPR. But in the non-shockable rhythm, yes, here comes the window for integrating cardiac ultrasound. And we do that by training the team to have first the machine ready at the bedside, someone allocated to use the ultrasound who is able to use the echo and knows how to use the echo, familiar with the machine, and he should not be the team leader, should not be doing anything else. And this person will perform the echo during the 10 seconds pulse check while the team leader provide clear communication to everyone in the room and provide instructions to that echo operator to perform the 10 seconds pulse check echocardiographic assessment. And this is how the team looks like. So again, you have the team leader, you have the person now, the person on the patient's right-hand side is starting assessing the patient by echo during the 10 seconds pulse check in the subcostal window, which is the view that we recommend for performing echo during CPR. I sometimes call it the life-saving view for people who are coming to learn echo from the beginning. I think subcostal is one of the most powerful views, especially during CPR. It does not interrupt chest compressions and it can provide a lot of useful information. And that's what the operator is doing at the moment. But this should not take more than 10 seconds. And the team leader should keep control of the whole situation. If nothing is seen, nothing is identified, the echo operation has, or the echo procedure has to be immediately aborted and the chest compression has to be started. The team should also be familiar, and the echo operator should be familiar with archiving, saving the images, and communicating the findings to the team leader and the rest of the team. And this is a recent work which we performed with Antonio Rubino and colleagues in Papworth and Italy, where we describe how do we use transesophageal echo during cardiac arrest from the emergency department to the intensive care unit. So it can help in different levels of patient care. Of course, it can help during cardiac arrest, but it can also help during cannulation and decision making for mechanical circulatory support, which is something we do more routinely now. Management of mechanical circulatory support, ECPR, if you want to perform ECMO CPR, echo is fundamental, especially transesophageal echocardiography. But this is actually one of my very favorite views. It's a very simple view and it does not require a transesophageal echo probe, and it can be performed very effectively, especially during ECMO CPR or ECPR. This is the transhepatic mid-axillary window where you put the probe at the mid-axillary line, perpendicular on the abdomen, with the orientation marker of the probe towards the head. And what you see now on the screen is the liver. You see the IVC under the liver where the blue line is, and you see the abdominal aorta where the red line is. And this is the double barrel view, which is really useful to guide the insertion of the guide wire, the venous guide wire in the IVC, the arterial guide wire into the aorta, all without interrupting chest compression while the Lucas is on, while the team is performing their ECMO cannulation away from the groin, away from the chest. Very, very useful. But that's not a substitute for later on performing transesophageal echo to confirm the cannula position. But that's really useful to see the guide wires in place with a very simple view. So finally, I think the bottom line, and I hope I was able to show you that what we understand so far on the use of echo in CPR is that it should not be used for prognostication during CPR. We should use it, of course. We should learn how to use it for diagnosis, to identify the reversible causes. It must not interrupt chest compressions. But like anything in echo, it requires training, it requires accreditation, which is really, really important. And I think very importantly, it requires training on the use of human factors in CPR, because we can be amazing in performing echo. We can have a very good team training, but we lack the human factors awareness of the dynamics of CPR. We all know that CPR can be a very messy and chaotic situation. So understanding the human factor role is really fundamental. And from this work, which we published now a few years ago, I will just quote this from the authors of our Echo in CPR chapter, Liana Shirley and Christopher Shirley, who said that even the right tool, if used in the wrong way, can lead to failure rather than success. Thank you very much and happy to take any questions.
Amazing. Hatem, that was gold. Thank you so much. That last comment, you're reminding me of James Rippey. I don't know whether you know him. He's this amazing emergency physician over in Perth, and he said that ultrasound in critical care, it can make a bad doctor dangerous, but a good doctor great, which I think is a lovely thing.
Wonderful. I love it. I love it.
Hey, thanks for a really great talk. I knew I was going to pick up more stuff. Hearing you when I was at the course, I think I was also thinking about trying to run the course, and I got a bit distracted. So I'm so glad I got you to do this, so I could pick up a few more bits. Um, First of all, so I guess my comment first of all is that the only thing that I sort of disagree about the research that you were putting up there was this idea from the Bernaccioli paper on the competency about having the field protocol and particularly echo in CPR as being that sort of bottom level of competency. I'm not sure I agree with that. I find that the people who are doing this, they cannot be people who are starting off at echo. You've got to be having, if you've got 10 seconds to get a single view with subcostal, you've got to be fast. You've got to know what you're doing. You've got to grab the report. You've got to have everything ready to go. Grab the loop. I find it challenging in the best of circumstances. You say it's chaotic, right? So I that's the only thing I sort of it gets my ears going up a little bit, which is the idea that you've got to have someone who knows what they're doing that view. Do you agree with that statement?
Totally. And you probably see me alluding more on this when I was saying that in many clinical situations, you need an expert performing echo
Yeah,
because first, the time pressure requires expertise in identifying some very important and sometimes subtle information, which is far away from beginner level. So I agree with you. I think performing echo in CPR is not a basic level.
yeah, 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 cool.
It is certainly not a basic level. Performing and interpreting, um, I agree with you totally.
Yeah,
And this is now probably this will requires reviewing because this pyramid was many years ago
yeah.
when critical care echo was starting. It was a great way of highlighting the different level of competence of critical care echo. But now we understand more and more that it is becoming more complex interpreting and performing echo in this context.
Okay, next thing, talk to me about focused TOE. I think this is an emerging field. I guess it's the next part of sort of point of care evolution. I've got mixed opinions on this, and I think you're
Mm.
going to need to help me out with this a little bit. There's this idea that we could have TOE having a pathway for this focused TOE. It gets me nervous in certain issues. Do you think you can have people doing focused TOE, particularly in resuscitation again? And I'm going to stick with this idea that doing focused TOE to differentiate causes of shock. That's Let me start with that first of all before I get into focused TOE with resuscitation. So let's call that resus TOE versus
Yeah,
focused TOE. So do you think
yeah.
focused TOE you can do it without having a knowledge of transthoracic echo, or is there a certain skill that you've got to get with transthoracic before you move into transesophageal?
Well, our anesthetic colleagues, they are the experts of transesophageal echo, and most of them have limited experience in
Yeah, good call.
transthoracic echo.
Great comment.
So, yeah, many of our anesthetic colleagues are masters of TOE, but they know nothing about TTE. So that's one thing to consider. Uh, I don't know the full answer, to be fair, but here in the UK, Antonio did a good job. I know it's a controversial, debatable situation, but he did a good job, and I helped him in several of the courses that he conducted. Now we have an accreditation pathway by the Intensive Care Society. on focused transesophageal echo, where it's a accreditation pathway. So now you can start and take the course and do the
Yeah.
logbook, where you get trained on performing the certain number of transesophageal echo views. I don't see it as an absolutely safe route. I share some concerns with you, but I think it's encouraging people to do more learning onto transesophageal echo. So if we have an accreditation pathway, why won't we do it? We know that the future of echo in critical care will certainly include more transesophageal echo.
Yeah.
Especially with miniaturized and small TOE probes, which will hopefully provide better and more continuous hemodynamic monitoring. So I think it's a good step for the future, but not without risk. And to mitigate the risk, we will need to be very careful with training. And I'm glad that we have the accreditation pathway in the UK. And I
Yeah.
actually, my close colleagues in my hospital share this concern. It becomes even more concerning in cardiac centers where you have very complex patients, and then you
And
would be
higher risk of
concerned
perforation and things, right? In these
high risk of
situations.
perforation, bleeding, patients on mechanical support, all this kind of stuff. But yeah, I
Yeah.
totally feel you and understand you.
You know, it's this idea. You had that great comment in the lecture where you talk about interpretation. You know, they're almost like these. I think trying to get the images requires a bit of kinetic learning, and then the next stage is the interpretation real time, which in a shock state, and particularly in CPR, is like next level. You know, you've got to be doing it super fast, and that requires sort of a higher level of experience and then being able to interpret it real time and then integrate it into the situation requires even a higher level of competence. And it's, I think each of those sort of three stages has a different level of experience required. But do you mind if I just tilt it again to talk in a slightly different area to ask for your tips about doing it with Lucas? Obviously, Lucas has sort of revolutionized how we do CPR. It's those human factors you talked about, which is so important to consider with CPR because it's a full-on situation, and it's obviously high pressure, high requirement for the team to work well together, and that's where the Lucas has such a great benefit in the fact that it kind of takes away some of that bandwidth you need for people actually doing the
Mhm.
CPR. Tips and tricks for using Echo with CPR because I've found it can be a little bit different. Do you any tips and tricks for people listening?
Yeah, absolutely. First, I think allocating what we do in the field protocol is actually what we do generally. uh, Peri-arrest or during arrest. Subcostal view is very important. We wouldn't attempt the other thoracic views. So subcostal window,
Yeah.
one person to be allocated the echo machine, and he does nothing else. And the team leader will have the clarity about the timing of starting, the communication of the echo findings with the operator and with the rest of the team, and making sure this echo does not, by any chance, exceed the 10 seconds pulse check. This is really crucial. And I can tell that most of the time we see the heart in the subcostal window. And during CPR, you don't have to see clearly all the cardiac structures. You want to have a clear idea. Is there a pericardial effusion? Is there evidence of massive pericardial effusion? Is the right heart bigger than the left? Although we know that this can be misleading, and many patients can
Yeah.
have what appears like RV strain
Yeah.
without any evidence of
I was
EE.
gonna I was gonna ask about it because it's such a common finding that in CPR you're gonna get the RV being a bit dilated because of the actual fact that they're in cardiac arrest, right? Yeah, nice comment.
Absolutely, absolutely. And actually, for another reason, because if people do echo in the apical window, it's a very common practice or common error to do it medially, and
Yeah.
that will
Like,
maybe will appear bigger.
yeah, yeah.
It's a really pitfall.
Do you use the subcostal short axis?
Yeah, actually, I
Yeah.
I I I, I keep telling you, we can do the whole echo study from the subcostal window. You
Nice.
you can do this even the three different levels of the short axis. And
Yeah.
if you have a very skinny patient, sometimes we get the bicaval view from the subcostal
Amazing.
in skinny people. So it's a really powerful view and
You don't
safe.
see a lot of those in Western Sydney, I'm afraid. No,
Oh,
kidding, kidding.
okay.
All right. Next question. You talked about diagnosis of tension pneumothorax with point of care ultrasound in a cardiac arrest. I find that really hard. I don't know. Have you got, I sort of find like I've almost maybe got myself into trouble with this sometimes. I don't know whether it's been from like a right main intubation or just that it's hard sometimes with an echo probe. If often you don't have the linear probe there. And just your
Mm.
thoughts on diagnosing tension pneumothorax during cardiac arrest with ultrasound. Is it always been perfect with you?
No, not at all. I share actually this was based on the data we have, but I personally struggle with it. Um, if we it's a, pneumothorax in general, diagnosing pneumothorax, the lung sliding itself can be very misleading for various reasons. As you said, right main stem intubation, and actually during CPR with ineffective ventilation, you will not see lung sliding.
Yeah.
But the key thing is the lung point. I think if you are lucky enough, or of course, patient is very unlucky, but if you are lucky enough to see the lung point, this will enable you to diagnose pneumothorax. But this can be very tricky in the context of patient in cardiac arrest. To me, diagnosing pneumothorax is clinical suspicion, and I have to tell you, and with complete honesty, um, uh, we might have to do chest X-ray sometimes if we
Yeah.
don't
Totally
uh,
agree.
address it quickly by ultrasound. But yeah, I think the data uh, are assuring, but I personally struggle with clearly diagnosing pneumothorax during CPR. Sometimes you get it, but many times you could miss it. Maybe because of the time pressure, maybe because of the dynamics of the situation.
Yeah, it's hard, right? Yeah.
Yeah,
Amazing. Do you mind if I just try and summarize what I've taken away from your lecture just to make sure that I've got it
of
fixed in my head? So, I guess there's an encouragement to think about, using ultrasound in CPR, and that is, and the key for that, the first and foremost, is it doesn't delay anything. It doesn't delay chest compressions. It doesn't get away in CPR, and its a main focus is for PEA cardiac arrest, and it's there to try and optimize the thought processes in terms of differential diagnoses, and it is not recommended to use it for prognostication. In terms of the people who are doing it, you probably need the most experienced critical care imaging person in the room to do it, similar to like you need someone who is the most experienced with the airway to do difficult airways. You need someone who knows what they're doing this. Subcostal is key. Any other views probably don't even think about it. And transesophageal echo is still contentious. But again,
yeah.
if you're adequately trained, there is time available. It doesn't distract from the CPR. It could be considered. Is that a reasonable summary of of what the evidence and what your lecture said?
Yeah, absolutely. It's a perfect summary. And I'm
Amazing.
reflecting actually on the pyramid, Sam. I think the pyramid because when it was initially described by Julie and then Susanna added price to it, I think the pyramid says, or what I understand from it, that it was an entry level to performing echo and CPR. And based on that, we had the field course, which is a great. I was the director for the field course at the Brompton for many years, and we trained a lot of junior doctors on performing echo and CPR. That's not a license to be an expert of performing echo and CPR, but I would see it as an entry level and not as an expertise level.
Yeah, nice. And RV dilation doesn't always mean PE. I think RV dilation can be common in CPR. So
Yeah.
again, it's important to try and take that into consideration. Um, and training is key, right? So doing it as a part of a team
Mhm.
and making sure you're adequately trained. Hatem,
Absolutely.
that was brilliant talking to you. Thank you for a
Thank you,
lovely
Sam.
lecture. Just wonderful talking to you, and just thanks again for the lecturing, getting Echo at Nepean, through 2025. And I'm really looking forward to 2026. And I hope we can have you back on to talk about many other things.
Thank you very much, Sam, for having me. It was wonderful to be with you and your team, and I wish you all the best and all the success to you and all the team in Nepean for 2026.
Well, you too. Happy Christmas, Happy New Year, Hatem, and talk
Happy
to you
Christmas, Happy
next
New
week.
Year, Sam. Thank you
Thanks.
very much.
Bye.
Bye. Bye-bye. Bye-bye.